pancreatitis and audit 5 years experience. Can you share your presentation again, please?
Yes, please.
Great. Okay. Go ahead.
Thank you very much again. So the next presentation is complicated acute pancreatitis and audit of 5 years experience. So again, the contributions from Shafiq, Salman and Professor Canalo. Thank you very much for supervising this project. So we know that the incidence of acute pancreatitis is quite high. It is up to 45 per 100,000 people annually. And we know that some of these patients, they progress from mild acute pancreatitis to moderately severe or the severe acute pancreatitis. And this is one of the concerns. The reason is that because if you develop moderately severe or severe pancreatitis, then you are at increased risk of developing complications and dying in the hospital or out of the hospital. And in 2012, they realized this. I mean, they had been realizing it since the problem exists, but in 2012 they realized that there may be a variation in practices, and there may be that they are not, and the clinicians or the team that is taking care of the patient are not actually realizing that some of the patient would be developing complications. So they revised their criteria, which is called as a revised Atlanta classification. And here the revision was that included 3 patients. They said there will be either a mild patient or would be a severe. Among the severe group, you can have a moderately severe or severe acute pancreatitis. So just the attempt was to stress on that if any patient develops a local complication or develops a systemic complication, that should be a severe acute pancreatitis. It would be moderate if it is less than 48 hours or local complication, or if it is more than 48 hours of organ dysfunction, then it will be labeled as severe acute pancreatitis. And this was the first that revised the classification. Now, second thing was they said that actually we should be using hub and spoke model, means that we should standardize our practices by every patient who belongs to category 2 or 3 must be discussed with the specialist center. And all the district hospitals which are taking care of such patients, they should communicate with them on weekly basis. And if the patient requires a transfer, then that should be early, and that should be based on decision by the multidisciplinary team. So this was a second modification or second intervention. The third intervention was a Penta Trial, which came in 2013, and it actually mentioned it would produce the data suggesting that any patient who get any sort of intervention, surgical intervention, before 4 to 6 weeks of time duration, they don't do well. So they suggested that these patients should be actually managed non-operatively as much as possible and should undergo surgery only if required after 4 to 6 weeks of period. So why we want to do a study? Because there are already established things. Well, we have done 3 interventions since 2013, but over a period of 7 years, we could find hardly any study which mentions what are the outcomes from the hub and spoke model and what are the outcomes after non-operative strategy or step-up approach. So the expectations are that there should be a decrease in the progression rate. The patients from mild attack should not be going into moderately severe or severe attack, number 1. And number 2, if they develop such infection, then we are so effective that there should be decrease in the mortality. Well, we were a bit skeptical about this, so we thought we should analyze our data. So if there is some area of improvement, then we should think about that. So this is primary objective and the aims of the study. The current study is aimed at reporting the clinical outcomes of patients with complicated acute pancreatitis managed at District General Hospital using hub and spoke model over a period of 5 years. Now I have introduced a new term here which is called as complicated acute pancreatitis. And this term is coined because the 2 categories, the grade 2 and 3, they actually have some sort of complication. So the moderately severe, they have a complication which is either a local complication in the form of acute fluid collection, pseudocyst formation, acute pancreatic necrosis, wall-off necrosis, or any other local complication. Or these are the patients who have organ dysfunction for less than 48 hours. And we have another category according to the revised Atlanta classification, that is the organ failure for more than 48 hours. So if we combine these two classes together, then we have a complicated acute pancreatitis group. It is important because these are the two classes which need to be managed, communicated with the specialist centers. So that makes the classification more pragmatic. Now, what is the mortality measuring? But we were measuring in hospital mortality and overall mortality over a period of 5 years. So median follow-up was up to 36 months. The morbidity, including need for an ITU, intervention rate, and length of hospital stay. And we defined conservative management if the care was ward-based and patient required IV analgesia, fluids, nutritional support, and the intent was curative, but we didn't do anything interventional. The supportive care we defined if the patient required only a symptomatic treatment and they are patients who are very high risk and not for ITU support. So we labeled them as a supportive care. And of course, this was in consultation with the senior clinicians and with the intensivist, and also discussion with the family. The remote care was defined all the patients of CAP who were discussed with the multidisciplinary team in the specialist centers. Now, of course, this is a retrospective analysis, but the data was actually being collected prospectively for the last 4 to 5 years, and it included both hospitals under the North Cumbria Integrated Care, and the duration was 2 to 5 years. All the patients who had a who met the diagnostic criteria of acute pancreatitis by IAP working group, they were included in the study. And the diagnostic criteria is either you have two of the followings, like pain suggestive of pancreatitis along with raised level of amylase more than 3 times. And secondly is or you have a CT finding suggestive of pancreatitis. Our project was registered as an audit, so we didn't require any ethical approval or patient consent. We used the usual method of analyzing SPSS 20 and means and standard deviations, medians and modes for the numerical variables, and categorical variables were measured as frequencies. We also did a Kaplan-Meier survival curve. Now, what are the results? So 401 patient had 496, about 500 episodes of pancreatitis. The incidence of the complicated acute pancreatitis was 21.72%. Like out of 401 patients, 88 developed some sort of complication, be it a local or systemic. Among these, 14% were moderately severe and 7% was severe pancreatitis, and these data actually matches with the international data as well, local, national and international data. The age varied from 21 to 97 with a mean of 62, and 62% of the patient were more than 60 years of age. Now it would be a bit strange to look at, but in this group we included only the patient who had complications, and we know from the Ranson criteria or from the Glasgow scoring system that age more than 60 is actually a predictor of complications. So it's no wonder that the mean age in this group who had some sort of complications were more than 60 years of age. Male to female ratio was 1:1, and I think we did well in terms of diagnosing the underlying cause. 76% of the cases, although recommendations are that it should be lower than that, but we couldn't find the reason for not having identification of underlying causes in these patients. Anyway, the 23% patient, they had an actually idiopathic pancreatitis. So the most likely cause was biliary acute pancreatitis along with the alcoholic pancreatitis. Underlying morbidities were found in 27, and these include diabetes mellitus and others. What were the radiological findings in these patients? So as expected, if you are doing a CT scan before the 4 weeks, then acute fluid collection and acute necrotic collections are the major findings on the CT scans. And after 4 weeks of duration, the pseudocyst formation was the most common finding. The other findings included acute pancreatitis, simple acute pancreatitis without any wall of necrosis, but these were included because they either had organ dysfunction without a local complications, or they had a severe organ dysfunction. There is one patient here which is no radiological evidence of pancreatitis. So there was a no CT evidence, but the patient was included because the patient had an evidence of pancreatitis based on epigastric pain and 3 times the amylase level. Now, how did we manage these patients retrospectively? So from the escalated fashions, conservative management, up to the CCU sport or sportive management. So these are the ways how we manage these patients. Most of the patients, they require a conservative management, and some of them they require in hospital ERCP or cholecystectomy during the indexation. A few patients went into ITU as well. So a few of the patients who required ITU but were not offered ITU because of their clinical condition where it was thought that they will not survive. So overall intervention rate, radiological, endoscopic or surgical, was 43%, and local complication beyond 4 weeks occurred in 20% of the patient. 10 patients required physical transfer to the surgery center, to the hub, which is only 11%. So it means that we were able to manage about 90% of complicated pancreatitis in our own hospital. And the follow-up data in the tertiary center showed that none of them required the once standard or not once a standard or once the necrosectomy procedure in these patients. The clinical outcomes with CAP, in hospital mortality was 10%, overall mortality was 14%, and 85% of the people, they were alive at 20 months after the index admission. And a few of them, like 35 of them, they developed chronic pancreatitis. The etiology in these patients were the alcoholic induced 28%, 13% of idiopathic, and biliary was 5%. So I think we were able to keep the recurrence rate in the biliary pancreatitis, which is the only reversible surgical cause for the pancreatitis, quite low. Now the comparative analysis, why we are doing the comparative analysis? Because we have combined the 2 groups together, which is severe acute pancreatitis and severe pancreatitis together as a complicated acute pancreatitis. And we can see very clearly that there was a significant variation in the complications among these 3 groups. And local complications were higher in the patient with moderately severe and severe pancreatitis, as is the admission to ITU, hospital stay for longer 5 days, in-hospital mortality, chronic pancreatitis development. When the chronic pancreatitis development was slightly higher in the patient who had a mild attack, and it's really understandable why it would be, because the patients belonging to moderately severe and severe acute pancreatitis, either they will die after a few years or they will have a cause which is not lead to chronic pancreatitis. So the patients who have mild attack, either they continue to drink if this is the case, or they might have an idiopathic cause. That's why the chronic pancreatitis develop more in case of mild acute pancreatitis, which is interesting finding. Mortality, follow-up duration. So the mortality was quite high in a patient who had a severe acute pancreatitis, while mild and moderately severe acute pancreatitis have a low in hospital and total mortality. So we do appreciate that this is a single center experience and it's a retrospective study, but I think it's a first of its kind in reporting the morbidity and mortality after the Penta Trial and after the suggestion of hub and spoke model. And it also provides a homogeneity in the patient groups, because we're getting a cohesive group of patients and in practices, because if you do a multi-centric trial, then there will be variation in practices, which should not be, but this is expected. Then the incidence of severe form of disease is still 20%. It's matching with the international data of 23%, 24%, but I mean, still it's the same as it used to be in the past. So what it means is that the progression from the milder form to severe form is still happening. And why it is important, we know that it will lead to some clinical, humanistic and economic outcomes, and the mortality would be higher in these patients. So what the points we are trying to make is that there is still the progression happening from mild attack to moderate and severe attacks. Number 1. Number 2, mortality is still in the range of 14 to 15%, which is still high in patients with pancreatitis despite these interventions we mentioned earlier. So it means that we are not still doing effectively. What could be effective? So I think And this is also, the point I try to make is also evident from the literature, because they have done, the Penta trial came from one of the European countries, and they have done penguin trials, tension trials, and all of them, they mentioned reduce in morbidity, but they haven't mentioned reduction in mortality. So it means that there are something we are lacking in the management of pancreatitis. And what are those things? We have got very nice meta-analysis and a systematic review from Heinz. We have mentioned that actually we should be doing something to reduce the inflammatory response. And they are looking at the role of infliximab in one of their trials, and dabigatran, because dabigatran will reduce the thrombotic complications, and infliximab will reduce the SIRS response. And there is another trial which is going on, and it is actually to determine the role of drainage of the acute pancreatic fluid during the early phase. Rather than waiting for 4 to 6 weeks, we should drain this fluid so that the SIRS response comes down. These are trials not reported yet, but we hope that in future we could get something out of these trials. So the progression from the mild to the moderately severe and severe pancreatitis remains high, and they have these group, they have a high mortality, prolonged hospital stay, and to improve the clinical outcomes, I think we need to do more than that. Like the effective preventive strategies or treatment strategies need to be developed. Thank you very much. I've taken much time.
Thank you for your presentation. Can you put on mute? Otherwise, everyone is listening to the echo.
Yeah.
Thank you. Kathy, any questions? Hello? Kathy, are you there?
On mute.
Oh, it's on mute. Okay. Team, please, any comments, questions?
You talked about the hub and spoke model and about looking at mortality and morbidity in a district general hospital. You presented your data. Do you have any feel for how that compares to data in a tertiary centre?
Well, it's a very interesting point. Actually, in tertiary centers, they are not accepting any patient who does not require an intervention. So there will be only the patients who have got complications and they require a necrosectomy, a step-up approach, or some sort of intervention. So we understand there are limitations, because the resources, if they try to take every patient from there, then they won't be able to manage the patients who need more resources. So it doesn't look practical, actually.
If I understood your data correctly, it looks like most of the interventions that occur in the district hospitals rather than tertiary centres. Is that right?
It is right. Because the recommendations are that unless you overcome the local resources, patients should not be shifted to the tertiary centre.
Sure. And in all those cases where there are intervention, was the tertiary centre in agreement? Because you mentioned there's a sort of an aspect of shared care, the MDT. Were the tertiary centre in agreement that the intervention should take place?
Yes, in a way that we will assume that this has been discussed with them, but individually each case's MDT decisions, I haven't gone through that. So we don't have the data stating that this was discussed with the MDT, but by default, every patient who gets severe or mild, moderately severe attack, they are discussed with the tertiary care centre.
Okay, thank you.
Thank you very much.
Gwen, any questions?
Yes.
No. I think Kathy is not connected at the moment. Okay, Khalid, thank you very much. I will let you know out in the early afternoon. So I think Mohammed is here.
That's not.
Kathy, sorry. You have questions about the paper?
I do, yes. So I'm just looking at your paper, and you described biliary stones as being one of the treatable causes, if you like, of pancreatitis. But yet the morbidity and mortality remains disappointing. The next bracket down was alcohol, and given that, an episode of pancreatitis is undoubtedly a teachable moment, and that it's painful, it's dramatic, etc., etc. I'm just wondering if anyone has put any efforts into a sort of a behaviour change program around those patients to try and improve mortality and morbidity?
Well, this is a very good point. Actually, the recommendation from the NICE guidelines are that every patient who has pancreatitis, their GP should be written about the preventable causes. They should be given information that they need to stop alcohol and smoking as well, because both of these are actually known to cause recurrent pancreatitis. So I think it's a good audit to be done again and see that how many patients at discharge they get and advise them and how they are followed up by the GP. But the current study didn't look into that data.
I'm just wondering whether or not that intervention ought to start in hospital on the surgical unit, given that that's where the teachable moment occurs. Once they're discharged and the pain has gone, they've lost the incentive.
Yeah.
But I think the teachable moment is when you're in pain and when you're in hospital, and I'm just wondering whether or not anyone is or perhaps should be looking at using that as the first site of intervention.
I think all the clinicians who are taking care of this patient at the registrar level or above, they speak to the patient once they come with the pancreatitis. This is my personal practice as well, that I talk to them and tell them this is the 3 causes which can prevent the future attacks are actually a biliary one, alcohol and smoking. So they need to change their behavior, and sometimes they do promise, but after a few weeks you see them again in the A&E. So I think
I think while GPs can say that how smoking and drinking are bad for you, but nobody's going to change. I'm actually looking at a psychological intervention.
Yeah.
So actually bringing in that psychological intervention at the time on the surgical unit.
That's a very good point. I think this is something we should look in the future.
All right. Okay. Thank you, Kathy. Any other questions, comments?
No, not from me.
Right. Okay. So should we do a break for 15 minutes? Starting at 12 again. Mohammed, can you please wait 15 minutes?
Okay, that's fine.
Okay, all right. We join at 12 again. Thank you.
Thank you, Prof. I will be leaving because I'm on night, so thank you very much.
Yes, thank you. We contact you in the afternoon.
Thank you.
Thank you for presenting. Bye-bye.
Bye-bye.